Okay, so we intentionally did not structure this as a debate. We also agreed that we all wouldn't pick on Alan, or each other for that matter. And you know, I think I got to say in the beginning that I agree with Lynn's conclusion that it's not so much the person, it's how we deliver it. But having said that, I was supposed to talk on pharmacists and hypertension, so I'll start. Here are my disclosures, and probably the worst disclosure is that although I'm a professor in cardiology, I'm a pharmacist. So you know, obviously, you take that with however much salt you want. Okay, so let me just start with, so why pharmacists and hypertension? I think there's a couple of key things that, just to point out, these things might already be quite obvious to you, but well, hypertension is a good one because it's mostly drug therapy. I mean, face it, diet and exercise are important, but face it, it's mostly drug therapy, and pharmacists know drugs. It happens mostly out in the community. So whatever solution we come up with, it's got to be, it's not something that is done in the hospital, it's in the community. More or less the monitoring and the diagnosis are relatively simple and not requiring hugely expensive equipment, so it can be easily done. I think one of the key points is that pharmacists are considered to be highly accessible in the community as primary care providers. And you know, the statistics you've probably heard before, but people see their pharmacist between 2 and 8 times more frequently than they see their physician. Having said that, that evidence is actually a little bit weak because it depends on how you measure it. But nevertheless, when we surveyed patients, what they like is the accessibility, free parking, not having to make an appointment, etc. But I think one of the very key pieces that probably doesn't get emphasized enough is really that that pharmacists can systematically case find. And you know, it doesn't matter if you have the best therapeutic knowledge in the world and all the tools in the world, it doesn't do any good if you can't find the patients that need them. And so having a systematic way to find cases is really important. And that's where the accessibility, of course, comes in and is really important as well. Most pharmacies have blood pressure machines, so you know, there's certainly the potential to case find, and we have and others have developed algorithms for how best to do that. And then the other part is once you find them. Oh, sorry. And the other thing is that, as you know, that 35% or so that are not controlled, a very large proportion of them don't know they have the condition. And so that's nobody's fault. It's just that if we don't have a way to get to them, then we have no chance of improving those outcomes. The second part of it, I think, is fairly self-explanatory. Medication management care follow-up, you know, is a key feature. So we have this need to improve hypertension management, and the opportunities in pharmacy have really opened up with a broader scope of practice, and so it's been kind of interesting to watch this sort of continue. So I think you all know this, but just to point out, and Dr. Kluche has already really done this, that you know, the highest level of evidence is considered randomized controlled trials, and the only thing that's better than that is a systematic review of well-done randomized controlled trials, assuming that the systematic review is done properly as well. So I'm going to skip over a lot of this other stuff and go straight to systematic reviews as well. And so this morning, Dr. Sanchi, if you were there, gave a great presentation on the evidence for pharmacist care and hypertension, and I just stole this from her. This was published a couple of years ago, and at that point there were 39 randomized controlled trials of pharmacist care versus usual care in about 14,000 patients. So this is actually quite similar to what you showed for the nurses, at the end of the day, the average effect on blood pressure was 7.6 over 3.9 blood pressure reduction, and the subgroup analysis said that there were greater effects if the intervention itself was pharmacist-led and that there was monthly follow-up incorporated into that. So again, you can see, or you can't really see, that the results are all pretty close to, well, they're basically all on this side of the line, which means that favors pharmacist care versus usual care. I do want to take this a little bit further, and some of our own research in Alberta. So what's changed in Alberta, if you don't know, is that a couple of years ago, pharmacists were given the opportunity to apply for independent prescribing authority. And so we were at the right place at the right time. So we actually, before this became really widespread, we had an opportunity actually to do a randomized trial. And I thought, when are we ever going to get to do something like this again? So we did this right in the very early days of pharmacist prescribing. So this was to evaluate the effect of pharmacist prescribing on systolic blood pressure reduction and in patients with poorly controlled hypertension. It was a randomized trial, 248 patients, all of whom had blood pressure above the target blood pressure, either 140 over 90 or 130 over 80 if they had diabetes. And this was conducted in 23 community pharmacies in Alberta. So the intervention itself was basically application of the SHEP guidelines that were current at that time. So that was what the training was around, and that's basically all it was. So it involved assessment of the blood pressure, cardiovascular risk calculation, patient education, and then, of course, the addition was here pharmacists took over the prescribing, referred to the physician where necessary, did also laboratory monitoring and follow-up, again, according to the Hypertension Canada guidelines. The usual care group, the control group, we had a bit of a problem with that because basically we were told we can't do nothing, so we had to do something. So basically what we did is we structured the control group as an active control, which was roughly equivalent to the control group on the systematic review that I showed you, where we were measuring blood pressures using BP True, you know, a full protocol for BP True. So we wrote those blood pressures down on a wallet card. We gave them written educational materials from Hypertension Canada, and then we told them to go and see their physician with those results. We didn't structure any follow-up visits other than a single visit at 3 months and a closeout visit at 6 months, just so we could catch their blood pressure. And in both groups, because we were measuring something, any lab tests that we did or any measurements that we took had to be shared with everyone involved with the care of that patient, which is standard practice. We screened 750 patients, 248 met the inclusion criteria, and 32 dropped out during follow-up. You can see the average age is about 64, about half were male. Fairly elevated body mass index. You can see diabetes was fairly prevalent, and baseline blood pressures, which were high-ish, but not super high. 80% of the patients were on antihypertensive therapy at baseline, so that was interesting, on an average of 1.7 drugs at baseline. This is not for dramatic effect, it's slow. So these are the main main results. On systolic blood pressure was our primary outcome. You can see actually in the gray, that's the control group. And there was actually a fairly large reduction in systolic blood pressure, almost 12 millimeters from 0 to 6 months in the control group. But there was a larger reduction of 18 millimeters of mercury in the Pharmacist enhanced care group that included prescribing. So that difference adjusted is 6.6 millimeters of mercury. And you can see also reductions in diastolic blood pressure. More patients got to their target, as you can see in the blue here, versus usual care. Just to take this a little bit further, so we presented these results, and people said, yeah, okay. So we thought, but what would this mean in terms of money? Because that's the language that policymakers understand, we think. And so basically we asked the pretty simple question. So if we had an 18 millimeter reduction in systolic blood pressure, what would that mean? It should reduce some strokes, I guess. It should reduce some heart attacks and kidney failure. What would that actually mean? So we worked with some health economists and epidemiologists to model what that would look like. And so those of you that know economic analysis know that any particular new intervention could have worse outcomes, better outcomes, or neutral. You could have higher cost or lower cost. And as you know, most things that we look at, that we talk about, fall in this quadrant where the outcomes are a little bit better, but the cost is higher, and then we have to make that tough decision as to whether it's worth it or not. In the case of using the RCT data for pharmacist care, in fact, it's better, and it actually saves money to the healthcare system. Let me just quantify this for you, if I can get this to work. So with that reduction in blood pressure, if you were to model this out, if you were to roll this out across Canada to half of the people with uncontrolled blood pressure, the strategy is dominant. It would save about 500,000 cardiovascular events over a 30-year period, and about a million life years saved, again, over that same sort of period, discounting it at 5% per year. And if you do the math for using standardized costs for these particular events, then the cost savings would be $15.7 billion, which is more than a couple of fighter jets, I guess, over that 30-year time horizon. So better and saves money. So I'm just going to wrap up here. As you know, the goal is better healthcare and better outcomes. And so if we want to address that remaining 35% that are not controlled, I think we need to think a little bit differently, and of course that's the purpose of us being here today. Pharmacists, whether you realize this or not, are primary care providers that are on the front line. We have pretty high level, robust evidence for this, for benefit in hypertension, where it's better and it's actually cost savings. So if this talk was about a new drug that I was telling you about, and I told you that you could, you got a reduction in clinical events, reduction in blood pressure, and it saved money, would we be clamoring to use this? You know, and I think we probably would. So basically, the message is that we've got pretty good evidence. What we don't have is across the country. Pharmacists can't do this across the country, and that's a barrier right there. If we could remove those barriers, which essentially is a signature on a piece of paper, although it's way more complicated than that, you could have 40,000 extra people helping, you know, in the fight against hypertension, working, you know, with you. And that's sort of where we're going with this, is to try to change that policy, because the data to us is pretty clear that it's beneficial. Anyways, thanks very much.